Thank you so much for taking time to join our webinar this evening. Our today's presentation is entitled MxA, which is a novel biomarker transforming acute respiratory infection diagnosis in children. My name is Dr. Sua, and I will be your presenter this evening. Let me start by saying this is the best time to practice medicine. This is because clinical diagnosis, clinical decisions are backed by evidence-based investigations than ever before. From the laboratory side, research shows that over 70% of clinical decisions are based on laboratory results. Today, I will present to you one of the newest clinical biomarker which will aid diagnosis of acute respiratory infections in children. This biomarker is called MxA. Acute respiratory infections are either caused by viruses or caused by bacteria are the main reasons why children visit hospitals. Most of these children, most of these patients end up getting antibiotic prescriptions. However, research shows that about 50% of these prescriptions are unnecessary. Let's look at the challenges which clinicians come across in an effort to offer appropriate use of antibiotics. The main reason why clinicians prescribe antibiotics is because of diagnostic uncertainty. Due to the dilemma concerning differentiation between viral infection from bacterial infection, patients who have got viral infections end up getting antibiotics. We all know increased exposure to antibiotics, it's one of the factors which has been given as a cause of antibiotic resistance. So let's look at the challenges which clinicians face in an effort to offer appropriate use of antibiotics. Number one is diagnostic uncertainty. Similar clinical symptoms which doctors encounter when treating children who are suffering from acute respiratory infections make it difficult for them to differentiate clinically whether a patient is suffering from a viral infection or a bacterial infection. As a result, in most cases, these patients end up getting antibiotic prescription. So that is the first reason. The second reason is time constraints. Doctors have got limited time to see their patients. Research shows that up to 90% of antibiotic prescriptions is done at the outpatient level. So lack of time by doctors to see their patient is another reason why patients end up getting antibiotics when it is not necessary. The third reason is patient's satisfaction. In some cases, patients or their relatives will request their doctors to give an antibiotic after visiting a clinician's office. The last reason, number 4, is because of expensive and limited diagnostic tools. Lack of diagnostic tools and limited resources at our primary care levels is a big challenge which our clinicians face in an effort to offer antibiotic treatment. So those are some of the challenges which our clinicians face in an attempt to make good use of antibiotics. In the next slide, we will look at the available laboratory clinical biomarkers which currently are in use, which are helping clinicians diagnose acute respiratory infection. So these are the challenges which our clinicians come across in an attempt to make good use of antibiotics. In the next slide, I would like us to go through some of the clinical biomarkers which our clinicians are using in an attempt to diagnose acute respiratory infection. Number one is white blood cells. WBC is one of the components of the full hemogram test. White blood cells has been used to identify severe bacterial infection. However, leukocytosis can be encountered in a number of other infections, and therefore its utility to differentiate bacterial from viral infection is limited. The second clinical biomarker is C-reactive protein. C-reactive protein has been in medical practice for a very long time. Elevated levels of C-reactive protein is seen in other cases like cancer cases, like trauma cases, and therefore its utility and diagnostic accuracy to differentiate these two types of infections is limited. Lastly, we have procalcitonin. Procalcitonin has also been used for a number of years. Procalcitonin helps to diagnose and monitor bacterial infections, including sepsis. However, its utility in differentiating these two infections is also limited. Therefore, in order for doctors to make informed clinical decisions in viral infections, a POCT biomarker is necessary. This is because acute respiratory infection is the common cause of illness and death in developing countries like Kenya. In one study done in Kenya, it was found that up to 45% of children visiting a medical center, their illness was as a result of viruses. The second reason is because of inadequate laboratory facilities. PCR is considered to be a gold standard to diagnose viral infections. We witnessed this during the COVID era. These tests are long, they are expensive, and they require extensive training. So as a result of these challenges, and in order to fill this gap, medical researchers have been looking for a rapid and reliable point-of-care testing device in order to help clinicians make accurately diagnosis for viral infections. This test is called MxA, and the full name of MxA is Myxovirus Resistant Protein A. So what is MxA? MxA is a blood protein that is produced by the body in response to viral infections. The role of MxA is to offer defense mechanism within the cells and therefore providing protection, providing immunity against viruses. MxA levels are elevated in patients with active viral infection, and the levels are low in patients with bacterial infections or in healthy individuals. This clinical biomarker, therefore, helps to differentiate viral infections from bacterial infections. So in summary, MxA can be applied in the following situations. Number one, to differentiate bacterial infection from viral infection. And then number two, it can be applied to monitor effectiveness of antiviral treatment. So MxA can be applied in these two scenarios. In my last part of the presentation, let me look at the new MxA test. Microbiologist Africa, together with their partners, Bodytech, have introduced a new test kit called MxA. This kit is combined with C-reactive protein in order to increase its utility in differentiating these two types of infections. The kit is reliable, has got a short turnaround time of 12 minutes, and the cost, it's affordable. It's a fraction of the already available MxA test kits. The kit requires only 10 microliters of blood, and therefore getting a sample from a child will not be a challenge. Lastly, let's look at the normal values for MxA and the C-reactive protein. The normal value for MxA is 0 to 15 ng per ml, while the normal values for C-reactive protein is between 0 to 20 mg per liter. As I finish, let's look at the interpretation of MxA test. Values above 15 ng per ml of MxA are an indication of viral infection. When values for MxA are above 15 ng per ml and the values of C-reactive protein above 20 mg per liter suggests a viral infection, and bacterial infection is also a likelihood. This slide marks the end of my presentation. Once again, thank you for joining us today, and I welcome you to get in touch with us for any further information which you might require. Thank you.